So somebody asked me yesterday about a visual field defect when we've done a workup and we have a negative MRI scan. And so you need to know that the places where the imaging study is not so good in imaging the optic pathway. So the first place where we're going to have a problem is the retina. So the imaging study, MRI, is not good for imaging the retina. So if you have a retinal visual field defect, of course the MRI scan is going to be normal. The retinal field defects are going to be ring scotoma or enlargement of the blind spot. Those two, especially when combined with photopsias, hemorrhaginopia, which is day blindness, or nyctalopia, night blindness, means the MRI scan is not the imaging here. You should be doing OCT and multifocal or full field ERG for retinal field defects. The second is the optic nerve and the chiasm. Normally when you have optic neuropathies, you see enhancement or you can see the compressive lesion. However, when the optic neuropathy is in the eye, in the optic nerve, the intraocular portion of the optic nerve, MRI is going to be normal. And of course, the most common intraocular abnormality of the optic nerve is glaucoma. So you're going to be looking for the visual field defect to correspond with the cupping. However, other optic neuropathies that are intraocular, posterior uveitis, non-arteritic anterior ischemic optic neuropathy, giant cell arteritis, they have no imaging correlate either. Once you get to the optic nerve and chiasm, normally the lesion is visible. However, about half the chiasmitis cases, no enhancement is seen. So if you think the patient has an optic neuropathy and it's not an intraocular form, you should still work it up even if the MRI scan doesn't show the enhancement. If the MR shows enhancement, then the usual suspects. Likewise, the tract is very difficult to image. So structural lesions in the tract can easily be missed, and the geniculate body. So if you've got the wedge sector anopia or the homonymous hemianopsia with an RAPD and band atrophy, those are notoriously difficult areas to image. And so a negative imaging study should not dissuade you from the localization in the tract of the geniculate body. In the radiations, those are relatively easy because in order to ding out the radiations, you have to have a structural lesion. However, there are conditions that cause a homonymous hemianopsia and there's no structural lesion because it's metabolic or it's a seizure, ictal or postictal, or it's subclinical ischemia, or it's an infection with the prion, the Creutzfeldt-Jakob disease, or it's degenerative, posterior cortical atrophy, the Alzheimer's, visual variant Alzheimer's. So we cannot see the metabolism, for example, in non-ketotic hyperosmolar hyperglycemia. We cannot see seizure that needs an EEG. We cannot see subclinical ischemia sometimes, or the scan is done too early. For that, we need to have DWI, the special sequence looking for the restricted diffusion from cytotoxic edema. CJD, the prion disease, that's the Heidenhain variant of CJD. Might show later the cortical ribboning on the DWI, but in the initial phases of the disease, the MR might show nothing. And of course, posterior cortical atrophy shows the atrophy, but it sometimes is disguised by global or more diffuse cerebral atrophy, and so a PET scan might be necessary to show the hypometabolism. So when you're confronted with a visual field defect with a negative MRI, you need to be looking at the retina. You're going to be looking at the places that are hard to image or could show no enhancement and still be a lesion. That's the tract and the geniculate. Radiation is normally easy. Cortex, metabolic, non-ketotic hyperosmolar hyperglycemia, seizure, ictal or postictal, subclinical ischemia, the Heidenhain variant, CJD, and posterior cortical atrophy.